So as you've heard yesterday, more than 1.3 billion people, adults, have hypertension. And almost 11 million of these adults die annually of hypertension. It is also known that 1 in 5 women have hypertension and 1 in 4 men have hypertension. But we've also heard yesterday about the complications of hypertension in women, and that it encompasses pregnancy, preeclampsia, as well as contraception that can complicate the situation of hypertension in women. We also heard about the awareness issue of high blood pressure in the world, and that is also the same for South Africa. We know that people are not aware that they have high blood pressure, and we also know that there's a large proportion of people that do not have their blood pressure measured regularly or haven't had their blood pressure measured ever. We also know that those who know that they have hypertension and they get treatment, that they are probably uncontrolled. And if we think about the rule of halves that Professor Woodworth has alluded to yesterday, is that half of the people have hypertension, half of them gets treated, but only half of them have their blood pressure controlled. And that is a big problem. And I want to put this picture here, and this is maybe on the light side, but I want to highlight that human behavior is perhaps the biggest reason why there is still uncontrolled hypertension and why lifestyle risk factors are still increasing the risk of hypertension and cardiovascular disease. We all have seen these kind of signs in public: do not step on this rail, do not drive with your bike on this pathway, do not swim. But there are risks involved, and that's why there are those kind of signs. And those are the same signs that we as healthcare providers have to give patients, but whether they follow those rules and those guidelines are not always in our control. So if we take a family like this, where you have the elderly and adults as well as children in the family, then there are several risk factors in each of those phases over the life course. So in the elderly, we know that with increasing age, in the majority of countries, there's an increasing prevalence of hypertension. But we also know that the elderly are more prone to have adverse drug reactions. So they have to be monitored and managed very closely. But then we also have the adults, of which we are in that phase, and we know that adults generally do not have time to go to the gym. They don't have time to cook proper food. They don't have they don't have time to make those lifestyle changes, and that is the typical argument that they follow of why they are not making these changes in their lives. So it's the no time phase. But then we also have the adolescents or the teenagers. We all know that they are hormonal and rebellious sometimes. And these are the children who experiment with new things. They smoke with their friends. They try to use alcohol. They make use of drugs. And those are all risk factors that can increase their risk of cardiovascular disease. But then we have the small child, and they are still very much influenceable. And at a very early age, we can make a huge change in the next generation of adults if we do this health education properly from very young ages. So this is a complicated summary of all the risk factors. I'm not going into detail with this, but these are the risk factors and its associated cardiovascular complications. And we know that these risk factors present in all your patients that you probably see in the clinic, in the hospital, or in your office. But what I want to highlight is that this is a study that was done very recently and published in the New England Journal of Medicine, where they looked at the cardiovascular risk factor composite in children and how it relates to cardiovascular events in mid-adult life. And this is quite shocking to see, and also not surprising. You can see that as the risk score increases of a child, the higher the risk of having a fatal or non-fatal cardiovascular event in mid-adult life. So I never thought I would put a doodle on a presentation, but I think this was the best way to explain what I want to say. So this is a complicated aspect we call high blood pressure. But I want to attach a person to each of these smaller doodles. So person A is an abused 15-year-old adolescent. Person B, a diabetic 56-year-old male. Person C, a multipartum 35-year-old pregnant woman. Person X is otherwise healthy and physically active 40-year-old successful businessman with anxiety. Person Y is a single parent, 26-year-old woman with an infant, working 3 jobs, small budget, and can only afford cheap, non-nutrient dense foods and uses alcohol as a coping mechanism. And person Z is a rural living farmer, 60 years old, smoker and overweight. All these people have high blood pressure, but all these cases have a different origin of high blood pressure. The cause of high blood pressure is different to each of these people. So individually we have complexity in someone that has high blood pressure. And as a GP, as a physician, as a nurse, you have to understand that complexity of the individual. Because in the clinical practice, there's another complexity. You have a combination of all these patients coming to your hospital or your clinic, and that makes it complicated, because what are we doing? We are treating high blood pressure. But are we treating the cause of the high blood pressure in each of these individuals? So we have learned much about blood pressure since yesterday, and it's a very simple measurement. But there are so many things going wrong with that measurement. There are also several things that can influence blood pressure, some of which we cannot modify. So that is our age, our sex, race, family history, heritage. But there are also certain adaptable factors, and that is medical history, environment, technology, politics, and the economy. We can adapt to certain factors. But then there are also these factors that we can modify as individuals. And that is the socio-cultural risk factors, individual factors, as well as personal circumstances. Now, we know that medicines are essential in treating high blood pressure, and the efficacy of medication is dependent on adherence, as well as proper patient counseling. But in addition to medication, lifestyle behavior is very important. A healthy lifestyle behavior is the first line of therapy for preventing high blood pressure. But in individuals that has high blood pressure, medication is important, but a healthy lifestyle has to accompany the treatment. And lifestyle is a lifestyle. It's not a quick fix. So it is not something that can be done quickly and it's over and done with, but you have to make a commitment to follow that healthy lifestyle. When you combine medication with a healthy lifestyle, it can reduce healthcare costs, less hospitalization and lower chances of morbidity and mortality. And that is the message we have to get across to the patients. Now, there are many studies that have indicated the benefits of lifestyle interventions. And I'm not going into much detail because time will not allow us. But there are several studies that have indicated that a healthy diet can lower blood pressure. And we've also heard yesterday that any diet works, but you have to follow that. But every diet doesn't work for everyone. I think that is an important message, because there are various food sensitivities, there are various cultural and religious components to diet, and we have to be sensitive to all these factors that can influence a dietary preference. And a healthy diet is also influenced by several factors, and we can't go through all of these, but I think it makes sense if we just highlight a few of these, that if you are not employed, you will not be able to afford healthy food. The same as if you are in a lower socioeconomic setting and there are less opportunity and less resources, you will not have access to healthy food. So that is the reality, and we all know in South Africa we have that kind of environment, and that is what we need to tackle. And in addition to diet, there are also other lifestyle interventions that can reduce blood pressure, and that includes salt intake restriction, weight loss, exercise, as well as the restriction of alcohol intake. We also heard yesterday that smoking cigarettes will probably not increase your blood pressure that much, but the harmful effects of the toxins and the chemicals inside cigarette smoking does have a large effect on vascular dysfunction. So it causes vascular structural damage, and it can also contribute to pulmonary disease and peripheral artery disease. And it has been shown in lifestyle intervention studies that the cessation at an early stage, stopping smoking from an age younger than 40 years of age, can reduce your risk of death by almost 90%. We also saw a similar slide yesterday that with the increase in alcohol intake, the blood pressure goes up. So the heavy drinkers will have higher blood pressure. And this was an interesting study for me, where they used a novel technology, which is a simulating device to simulate physical activity, but while you are in a sitting or lying down position. And I think I want to get one of those devices. If you look at the data, the colored lines are the ones who were in the experimental leg of the study, and they all showed reduced blood pressure by having this simulated physical activity, whereas those who did not have the physical activity intervention had increased blood pressure. So physical activity is really a good therapy for lowering blood pressure. This is a lot of information, and I just want you to focus on the bold text in the pink columns. And those are the effective interventions that are currently in place with several of these risk factors. But there are still a lot of these effective interventions that needs attention, in South Africa especially, where we need to have the government on board with helping spreading this message of healthy lifestyle across the country. And you will see that in the physical inactivity column, there's no intervention yet on a national level. So when we get to patient counseling, what I would like to highlight is that there's a large disconnect between the medical doctor and the patient. And I think we all realize this, and we all know about this. So the GP is typically authoritarian, directing, takes control and the choice away from a patient, and is very provider-centered. And this is very typical for smaller towns where I come from, where that is the practice, where the patient is sometimes very self-directed, and they empower themselves with incorrect information from social media, from false news, and from Google, Dr. Google. So there's a huge disconnect between the patient and the doctor. And what we need to highlight is certain skills that are very important when a doctor has a conversation with a patient, and vice versa. And the most important one for me is the one in bold, is the word listening. It is very we are chasing time, and there are many people coming into the clinic, but we don't make time to listen to a patient, to really understand the environment where that patient comes from, their circumstances, in order to treat the individual and not the symptom. So this is a nice model of the progressive stages of readiness of behavioral change. As a doctor, we need to analyze the willingness of a patient to make a behavioral change. And the patient enters in the pre-contemplation phase, that is almost on the center of the slide, and then they contemplate, how are they going to do this change? Do I want to make this lifestyle change? And when they are determined to make that change, you as the GP have to empower those patients with giving them the proper resources and help them understand what is the best way forward for them to make a success of this behavioral change. Then there's the action and maintenance if someone can push through and continue with that healthy lifestyle. But mostly there's a kind of relapse where they have to start this contemplation phase all over again, or when they are determined to make the change, they say, I will start on Monday with my new lifestyle change, and that Monday never comes. I'm sure you've all heard of the 5 A's, or now they also talk about the 6 A's, and this is to ask the patient about their risk factors and their behaviors, to advise a patient on changing their behavior, to assess the willingness of the patient to make such a change, and to assist the patient by providing proper educational resources, send them to your multidisciplinary team if they need help from a nutritionist, a dietitian, or a biokineticist, or whoever, a psychologist, and you have to help them get to those resources. And then lastly, and very importantly, is to arrange follow-up. I think that is something that we neglect a lot, is you treat the patient and off they go. But do we really follow them up and refer them? Then there's also this technical package from the World Health Organization, healthy lifestyle counseling. That is what we just spoke about, and they have very comprehensive packages for each of these topics, and then evidence-based treatment protocols. And I think we are lacking on that end, because we are drowning in a lot of guidelines that is available from several countries, but we lack the proper South African context, guidelines and protocols. Then access to essential medicines and technology. We know that sometimes medicine is not always available. Technology is sometimes failing us. And then team-based care is very important. Working with lifestyle behavior and change in lifestyle behavior is not a one-man's job. There are many people involved in order to help the patient to make those decisions and to follow through on a healthy lifestyle. And then systems for monitoring. I think there we are also failing, because we have no registry, we have no form of communication between provinces and hospitals, and I think that is an aspect that we can definitely look into in the future. There are several barriers to deliver effective patient counseling. The one I want to highlight is the center one, when there is conflicting lifestyle messages. And this is conflicting messages from a doctor and a nurse. So I know you probably saw that doctors smoke camel slide yesterday from Prof Neil Poulter. And that is the thing. If you're a doctor and you're a smoker and you advise a patient not to smoke, then you are sending the wrong message. And the same goes for the nurses. So whatever you communicate to that patient should be the same language from both the doctor and the nurse. There are several tools and resources. This is very small, but I will provide you with all these links if you want this, to empower you in patient counseling and lifestyle interventions. And then lastly, one of the very nice resources is the Omron Academy. That is an online and free platform with very nice short courses that really takes no time at all. It took me 1 minute to register for the online academy, and I can really promote this. It is developed by scientists and endorsed by leading societies. And there are several short courses that is in line with your scope of practice. Lifestyle counseling as part of one, but you will see that there are several other modules at the bottom for monitoring, self-monitoring, remote management of patients with hypertension. Thank you very much.